Three, two, one. Liftoff.
Welcome back to the Ketamine Startup Podcast. This is where we talk about anything and everything related to ketamine clinics, marketing, and more. In today's episode, I interview Dr. Lara Edinger, who owns Edinger Pain Management Clinic in Los Angeles. Dr. Lara Edinger specializes in the treatment of chronic neuropathic and musculoskeletal pain disorders. She's board certified in neurology and pain medicine. In addition, she's an assistant clinical professor at UCLA Department of Neurology. Her area of expertise includes complex regional pain syndrome, post-traumatic headaches, pelvic pain, peripheral neuropathy, fibromyalgia, mast cell activation, as well as phantom limb syndrome. Please stay tuned for this awesome, informative podcast interview with Dr. Edinger. Let's dive right in. Welcome to the Ketamine Startup Podcast. Thank you so much for joining us, Dr. Lara Edinger. We are here live at the American Society of Ketamine Physicians, Psychotherapists, Practitioners, ASKP3 conference in Austin, Texas, and just wanted to take a moment to connect with some experts in this space, and you're one of them. So before we get started, can you tell us a little bit about you, your background, maybe your education, just so that some of the listeners can know more about you?
Yeah, sure. So by background, I'm a neurologist. I went through an interesting neurology program where we had actually the largest CRPS clinic in the world at that time. As a result, we did a lot of lidocaine and ketamine infusions. Our protocols in residency included, of course, inpatient ketamine in the ICU and extensive outpatient ketamine program as well. And so having been introduced to that early on, I became very interested in CRPS and the use of ketamine. I then went on to do a pain fellowship at the University of Virginia with the anesthesia department. And there I was invited to help them come up with an inpatient ketamine protocol for CRPS patients, which they hadn't done before. So that was really exciting and really fun. And I actually did the first infusion for a CRPS patient in UVA.
Wow.
Yeah. So I got to do that. They had been using it somewhat in palliative care at really low doses. So they were somewhat familiar, but that was, so that was very exciting. After that, I just went into private practice. I worked for a clinic. I worked for another physician. And then in 2017, I started my own practice. So.
Nice. And what is the name of your practice?
It's Edinger Pain Management.
Perfect. Makes sense. And it's in
Westwood,
in Westwood.
Los Angeles.
In Los Angeles.
Yeah.
Wonderful. Wow.
Yeah.
So since 2017, that's actually pretty early if you think about it in the ketamine space as far as number of clinics.
Yeah, I guess. I mean, in my view, I don't know. I was trained with somebody who'd been doing ketamine for 30 years.
Yeah, that was Dr. Schwartzman
That
you
was
mentioned,
Dr. Schwartzman,
who published
yeah.
a ton of research in the CRPS, because I remember that name sounds very familiar.
Yeah, he published multiple papers in CRPS, and he also published papers on ketamine infusions as well, and lidocaine infusions.
Got it.
So he was one of the really earliest ones to start using ketamine in this country for pain control and for, other than anesthesia purposes.
Very nice. So for our listeners who don't know what CRPS is, can you just briefly tell us what that is?
Yeah, it's a neuropathic pain disorder. It stands for complex regional pain syndrome. It's a disorder that typically arises after an injury. It can be a very minor injury, most commonly after fracture. And it's basically a syndrome of inappropriate pain, where the pain just continues on and on and on. And it really is not regional. It really is a central nervous system problem. And you see all the subsequent signs and symptoms, which include, vasomotor symptoms, which is swelling, or not swelling, I'm sorry, but is temperature changes and color changes. And then you have pseudomotor and swelling, which is, of course, you have a lot of edema, spontaneous edema, particularly. Sweating changes. The limb often becomes very sweaty in comparison to the other one. And then lastly is motor trophic. And motor can be, a decreased range in motion that's really out of proportion to what happened, or it can be dystonia, it can be myoclonus, it can be rather dramatic.
Wow.
Rarely, but that can happen. And then, of course, trophic changes are reference to, the shiny skin that we typically see, increased hair growth, increased nail growth, So it's a very interesting disorder, and it's also often associated with other autoimmune diseases or conditions. So basically, that is what the majority of my population has. And then intermixed there is various other neuropathic pain conditions.
Yeah.
So,
And CRPS is pretty rare, I would say, or please correct me if I'm wrong. Do you know the prevalence? Is it 1%,
well,
2%? I know it's
they say it probably occurs to some degree in about 2% of
2% of the
all
population.
injuries.
Wow.
Yeah.
Oh,
But then it
volunteers.
often will kind of come up and then go away again, which we
Hmm.
never capture those.
Got it.
Those, we think that could happen. I've actually captured that twice
Got it.
where I thought somebody was going to go into full minute CRPS and for whatever reason they didn't,
Yeah.
which was very interesting to see that. But, probably 2% probably captures those people who have some degree of allodynia or pain with light touch after a surgery or after an injury.
Hmm.
And this population actually could be higher. I've heard that some people feel it's up to 15%
Wow.
actually, which I think is really under-recognized.
So definitely the link of the autoimmune
Yeah,
conditions with
yeah,
CRPS.
yeah,
Yeah. Okay.
yeah. So
I am really curious, you know, going from, I know you train as a neurologist and you've had the fellowship, and kind of going from that traditional healthcare provider clinician model to opening up your own practice.
yeah.
What was there, like a pivotal moment or an experience that had you take the leap? Because, I remember reading some report by the AMA that, the vast majority of physicians are actually employees of large healthcare
Right.
corporations.
Yes.
So for you to kind of go out and do your own thing, like, was there a moment or a transition?
No, it happened sort of suddenly. I mean, basically, I came to LA. I was working with another physician there who was thinking he was going to retire, but then through a whole bunch of other events, he really couldn't. And so I came down, and basically, it was a matter of lack of space, lack of space, and a lack of personnel that could really handle another physician in that office.
Mm.
So I made the decision that's probably best to strike out on my own. So I wasn't exactly prepared as much as I would have liked to have been, but I happened to have a small population of patients in LA at that time, and I didn't want to abandon them, and I just wanted to sort of see what happened. So I did it. I went for it.
Wow. In med school or residency, we're not really taught to open up our own practices.
Right.
So it was a big leap. So I'm curious, what's an unexpected challenge that you face as you open up your own clinic?
Trying to figure out how to manage the business side of things is really challenging. I started off trying to take insurance, and I didn't understand that when you first start a practice, the insurance companies will give you the absolute lowest contract they can.
Hmm.
I didn't know that. Actually, my patients actually told me because
Wow.
I didn't have that many, and so we're close. We knew each other very well, and they're very complicated, and they've been through the healthcare system a lot, so they actually knew more than I did about
Wow.
insurance, and they kept telling me, you're getting paid a lot less than my other providers. And I had one patient who advised me, like, you need to stop taking insurance now. I'm sorry,
Whoa.
but you can't do this.
Hmm. Hmm.
So actually, it's my patients that helped me out, ironically.
That's perfect. What a
They
gift.
really help. Yeah, they really helped me out on that because they're just like, yeah, I have one patient in particular who's really good at medical billing
Uh-huh.
because he's just figured everything out over the years. And so, yeah, so unfortunately, I couldn't take insurance. So I'm totally cash pay, but we do give, of course, super bills to our patients and
Sure.
help them with codes and help them write letters. I mean, try to do everything we can
Yeah,
to make sure
nice.
they get some money back.
Wonderful.
So that was a real shock and a
Mhm.
challenge. And I'm still in Medicare because the reimbursement's not that bad in Medicare. But I had all sorts of Medicare issues in the beginning too. Like they owed me so much money. Like
Wow.
we couldn't get them to pay us. It was very complicated. And it had to do with I was also a voluntary faculty member at UCLA.
Mhm.
So if you're involved in, and I also had a part-time job too at another pain clinic, Universal Pain, up in Palmdale. So if you're at 3 different locations, Medicare gets very confused,
Mm.
apparently. And
Yeah.
they think they were sending checks to like UCLA, Neurology. So I just want to warn people about that. So that was very challenging. Yeah, so unfortunately, I just couldn't figure out how to take insurance. The other thing that happened too is that I looked through a whole bunch of medical billing companies, and I would sign up with them, but then they wouldn't bill for me. They just wouldn't do it. Because the reason is that when you're so small, there's really nothing in it for them. Like they get paid per, you know what I mean?
Per
How much
patient
you,
or
or per profit, like,
Yeah.
or how much profit you make, or, there's always some like baseline, and then they obviously expect to make some commission.
Sure.
And there's just no motivation for them to help you.
Interesting.
So I got screwed a lot in the beginning.
That's good to know, because
And also, I also
uh-huh.
I also tried to get billing through my EMR, and they were also not good. Not good. So I probably lost a few $1,000s.
Wow. Well, it's really useful to know about the insurance. And I mean, for me at my clinic in Palm Springs, I actually just had a patient email me.
Yeah.
And she said, hey, by the way, I just got covered, or they fully reimbursed me because we provide super bills.
Yeah. Yeah.
And one of the things that I did was gave them the CPT codes, ICD codes. And then there was a recent article published in the New England Journal of Medicine, ketamine versus ECT.
Yeah.
And I said, also submit along with your super bill this research article and this meta-analysis.
Right.
And I think by her submitting the super bill, and I could be wrong, but anyway, she got fully reimbursed.
Wow.
Which was kind of cool. I feel like the insurance companies are kind of changing these days.
I hope so.
With coverage, at least for depression, maybe not for CRPS.
Yeah, for pain, I don't know.
Yeah.
Just because I had to give such high doses.
Yes.
It's such a long infusions, 4 hours. So it's a little different, but I'm glad they're covering it in some respects.
I mean, and sometimes I have had it where the patients get 0% reimbursement too. So it kind of depends.
Do you remember what insurance company did that? I'm just curious.
I don't recall, but I can tell you offline what it was. Yeah.
Okay.
Because I know I had one person who worked for a large software company based out of Palo Alto, super well known, and they had excellent health insurance, and they got reimbursed. I think 60% or something.
Yeah.
So I think it also depends upon which insurance company. I think that the person has.
Yeah, I'm just curious because I'm still. I tried
Yeah.
many times to get it covered by insurance.
Sure.
But failed, unfortunately. So
well, thank you for trying.
Yeah.
For those unfamiliar, or for those people, the listeners who are not familiar with kind of the nuances of ketamine therapy, because when the traditional physician or clinician thinks about ketamine, they're like, oh, in the operating room or in the ER for this little toddler with a laceration, or they're going to do some procedure, spinal tap or whatever it may be. How would you describe kind of like the nuances of how it's done in maybe in the hospital type environment in the ER OR versus how you do it, if there are any nuances?
Yeah, there's several different nuances. I mean, of course, I'm not trying to put people under, like, anesthesia per se, right? They're all very well obtunded, and we're probably at the level of monitored anesthesia care in a lot of cases. But yeah, we're not trying to, I think in the OR, obviously it's a very dynamic situation in the OR, and they often have to give like more boluses, or they have to adjust things, or they give more propofol, or they mix them, or, so there's a whole different situation to do it procedurally than what I do, whereas, I go in and I assess them and I kind of figure out how much I think they need. And then I stay at that rate. The vast majority of the time I stay at that exact dose and rate for the remainder of the infusion. And as far as like there is an art to it, of course, the further I get along, the less standardized I've become. I always start people with a 3-day infusion to figure out if it's even going to work for them in terms of pain control, or are they going to tolerate it, or what kind of side effects am I going to have to control, or what dose they need. So that portion is very standardized. Those start at 100, and then I increase by 50 to 100 each day, ending up about 300
in a 4-hour period by day 3.
Yeah,
got it.
Yeah, in a 4-hour period. And some people, it becomes very obvious that their tolerance is higher, a lot higher. So then, of course, sometimes I end up higher.
Got it.
And then hopefully that is therapeutic. And then we come back, and usually they just need boosters or another 3-day session or another 3 to 5 day session. But in certain cases, I actually have to go 10 days.
Wow. In a row.
In a row. Yeah.
So
through
including
the
weekends.
Yes.
Okay.
Yeah. It has to be done in a row for CRPS. That's the only way it's going to you're really going to optimize the situation.
Interesting. Good to know.
So it's very intensive. And for this kind of level of pain that I deal with, and sort of these extreme pain situations that are refractory to other types of treatment, you have to be really, really, really aggressive.
Wow.
That's including also, before I do that to somebody, trying to get as far as I can with sympathetic blocks and with medications.
So they've already tried X, Y, and Z.
Yeah, but I try to keep them on some medication regimen that actually will help a little bit. And that usually includes 3 to 4 different medications.
Wow.
So it's very aggressive.
Yeah. And this conversation is actually really useful for me because I feel like you are one of the experts in CRPS, especially you trained with Dr. Schwartzman. So this is really, really useful because I feel like when I review the literature for chronic pain and CRPS, there's quite a bit of variation in the protocols.
Oh yeah, there's
like
a huge variation.
Huge variation. Like some
Yeah.
people are doing very low dose, and some people are actually, like I heard about in Mexico. I think it's Monterrey.
Yeah, Dr. Cantu, I know.
Where they're doing like ICU level, like 24 hours per day.
Yeah, it's Dr. Cantu, and he's a very nice guy. I actually know him very well. Or not well, I mean, talk to him, but we sent patients from Hahnemann Hospital to Mexico to him specifically when we couldn't possibly treat them anymore, and they just needed to go and go into a ketamine coma. Yeah, and so he's been doing this, oh my gosh, at least for 20 years.
Yeah,
or something.
I think he's one of the few. I think there's one in Germany who might be doing it.
Germany actually stopped.
Did they stop? Okay.
As far as they stopped a long time ago. They may have restarted, not that I'm aware of. They stopped because they had 2 patients get pneumonia associated with intubation.
Got it. So Dr. Cantu in Mexico, he's doing 7-day, 10-day.
I think it's the 5-day. It's usually 5 days
for 24 hours. That sounds
24
really,
hours a day.
Yeah, that sounds. And speaking of CRPS, and I think this is kind of in the news, and I don't know if you've heard of this documentary called "Take Care of Maya," or if you've seen it, and kind of the outcomes.
I can't watch it.
Okay, I watched it because one of my patients was like, "Hey, Dr. Ko, this is about ketamine," and I watched it, and I got really sad. Trigger warning, there's suicide in there. And it's very sad, but also at the same time, like eye-opening. Yeah. But they had a patient in there with CRPS who went to, I believe, Monterey. Yeah.
And then they didn't understand it. They didn't understand why, from what I've heard. Yeah. Honestly, I can't watch it because I heard so many of those stories in residency, and I can't bear to listen to it unless I'm involved and I'm doing something about it. Yeah, we're like, by the time the patients got to Dr. Schwartzman, they basically had CRPS everywhere.
Wow.
Like what we would call,
goodness.
Like, it's an oxymoron, but total body CRPS.
Yeah.
Like, basically that's what they had.
Wow. Yeah.
And all the associated, systemic side effects. Or systemic complications, I should say.
Yeah, and it's kind of ketamine. Like in California, at least we're well aware of it, but in other states or other medical cultures or societies, the case that happened in Florida, like the practitioners weren't even aware, and they were like, ketamine should not be used for CRPS, and there was just this lack of education and ignorance, which is one of the reasons why we wanted you on the podcast. Is like, let's hear more about this and kind of get information out to other clinicians. Like, this is a real thing. It can be beneficial, not for everyone, of course.
No,
but it can be helpful.
It's not the first line treatment. I mean, like I said, I always try like conservative care first.
Sure.
I always try sympathetic blocks. I always try, but if it becomes clear that nothing is really gonna work, then then ketamine is definitely a great option.
Yeah.
And I do feel that most pain physicians I speak to now, in regards to CRPS, really are recognizing that.
Nice.
And also, I don't have any issues anymore with advising anesthesia to use ketamine for CRPS patients during operations, because, I have a protocol and I advise them, like, okay, this is what you need to do.
Nice.
And really no pushback on that. Like, they're starting to use ketamine more and more, and they totally get it. And so it's been a great change to see that.
Very cool.
Yeah.
And now a quick word for our aspiring ketamine clinic founders out there. If you've tuned into our episode today, chances are you're curious about the ins and outs of starting up a ketamine clinic. It's an exciting field, but let's face it, the journey from idea to actually opening day can be quite daunting. That's why we've created something special for you. Think of it as your personal roadmap, a free downloadable checklist that lays out the essential steps you need to consider when starting up your own ketamine clinic. This checklist is designed to help you avoid common pitfalls and launch your trajectory to success. So how can you get your hands on this checklist? Simple. Just visit www.ketaminestartup.com/checklist and grab your free copy today. We've made it easy and accessible because we believe in supporting our community with valuable resources. KetamineStartup.com/checklist. All right, let's get back to our discussion. Stay tuned and don't forget to download your free checklist during or after the podcast. So I'm curious, you've been open since 2017, and as your clinic has grown and developed, what strategies or approaches have you personally found to be the most impactful for the success? Because there's this statistic that, for every 5 businesses that open up within 5 years, only one will be existing. So you've been open for now 6 years.
6 years, yeah.
So is there anything kind of from the business perspective or management, like what have you found to be most impactful for its success?
Well, I think first of all, I think the thing I have in my favor is that I'm treating something very rare. And I also, not only CRPS, but I also treat like extreme pain disorders that are either undiagnosable, like we don't really know why or how they come about, or, extreme sort of headache situations, like people are suicidal because the headache is so bad, things like that. So I think because I sort of am taking on, frankly, the worst of the worst situations. And I am the doctor of last resort after Mayo Clinic sometimes. And so that's kind of intimidating. But I think I have that going for me in a sense that that market isn't really well covered.
It's a tough market. And
it's
also
not like, you know what I mean? It's not like I'm doing regular pain or I'm
Gotcha.
doing like a whole bunch of epidurals or, I do mostly sympathetic blocks. I get the occasional back pain case where I'll do radiofrequency ablation, but it's not something that's not my bread and butter at all,
Got it.
And so I'm like in this totally different realm, I think. And the other thing too is because my patients have been through so much and they have so much PTSD regarding interacting with the medical field in general, that one thing I think has really helped us is that we are actually trying to be as casual as possible in the office.
Nice.
I have 4 young women who run the office with me. They're all very personable. I let them wear whatever they want. They can come at, it's just a very relaxed environment. And so, and we do that on purpose to make people feel comfortable and not to, and I'm also a very available, which is hard, but I am very available for my patients. And a lot of them require a lot of close follow-up in order to get them through the crisis and get them through stabilization. And so, I'm concierge, right? So I'm on the phone a lot.
Yeah, a lot of literal, sometimes hand-holding,
phone
calls and text messages.
definitely.
So it's pretty intensive.
Yeah, it's intensive, but it's very rewarding because I go through those periods with patients, and then now I have patients where I used to be on the phone with them constantly, and now it's been years and they're fine, and they call me every once or twice a month or even once every 3 months.
It's got to be so
they're
rewarding.
fine.
Yeah, because they were in that acute crisis pain, and then they're more stabilized.
And it's great.
Maintaining, and that's wonderful.
And I have patients now who call me sometimes at home, and they're like, "I'm fine." That's the first thing they say.
I'm fine.
Don't worry, I'm fine. I'm like, okay, thank God.
Yeah.
But yeah, no, that's really cute. Like they call me and they're like, "I'm doing great," and I'm like, "Okay, good." And then it's just some minor issue that they needed to, have an answer to right then, and so that feels really good. So it's really rewarding.
And so what I'm hearing is kind of 2 things. Number one is like you've kind of niched out in a very challenging patient population,
right?
Or patients experiencing a challenging situation,
right?
And then number 2 is I know you mentioned a casual setting, but I also think about this concept within the psychedelic space. They always talk about set and setting, right? Set and setting, which Tim Leary invented, and it's like
absolutely.
I noticed that as well.
Yeah, it's really important. Yeah, I just want them to feel comfortable and feel like, that everyone in there are sympathetic souls, and so I've been really fortunate to find the right people to help me create that. I've been very, very fortunate. Yeah. So, thanks to my staff. I couldn't do it without them. So.
And sometimes I feel like in modern healthcare, we lose that because
Mhm.
I was talking with another doctor here, family practice, and he
Right.
was telling me he sees 40 patients per day
Oh,
and he has 15 minutes per patient.
no.
And that's not including documentation time. And so it's
Wow.
like 15 minutes, 15 minutes. And they may have, multiple
I know.
issues that need to be addressed, but it's like you get
I
15
don't
minutes and it's like,
know how
that's challenging
they
for
can
sure.
do it. It's so hard. I mean, I was in a pain clinic, my part-time job, I was in a pain clinic where we saw up to like 18 to 22 patients per day. And despite the fact that they were high volume, I really did feel like they did a very good job because they employed so many MAs to like just back us up in every way possible. But it was extremely challenging. Even in sort of like, I feel like the best possible scenario, it was still very challenging.
Yeah.
Yeah.
Well, I'm really
So,
glad you
yeah.
have your own practice and I mean, for me, because I own a clinic as well, it's like
Uh,
one of the things I love and value is autonomy.
right.
Like, hey, I don't
Yes.
have some administrator telling me to do X, Y, and Z or
Right.
do this online course. It's like, well, and if I want to make a change,
Yeah.
I can institute it immediately. I
Yeah.
remember when I used to work in the ER, I wanted to add a chair to the physician space. And they were like, okay, we have to bring it up to the meeting and run it by the committee. And I was like, I will buy the chair on Amazon. I will
I
pay
will
for it.
pay for
And
it.
they're like, no, we have to run it through the committee before you can. And I was like, oh, this is ridiculous.
Yeah.
Whereas now it's like, if I want a chair, I'm going to order a chair
I'm going to
and
order a
get it
chair and get
delivered in
it.
2 days.
I know. Yeah. It's really rewarding to like sort of be in control of the situation, especially because my patient population is so challenging that they've tried all the normal routes, right? So I have to kind of really go off, you know, sort of down the garden path with them, right? To find whatever will work. And if I had to try to do that in an institution, there is no possible way I could treat these people.
Yeah.
That's just a fact. Unfortunately, there's just no way.
That's
So,
the reality
yeah, that's a
sometimes of
reality. Yeah.
current healthcare system.
Yeah.
And yeah, and I do notice a lot more cash-based practices coming up,
Yeah.
direct primary care, for
Yeah.
example. So it is
Yeah.
changing slowly.
Yeah, it's a tough thing. I mean, I am also starting a nonprofit this year, and I'm going to try to, it's basically going to be for complex patients with chronic pain.
Hmm.
So I'm going to try to see if I can get funding for patients who don't have the means to pay, like
Wow.
whether for me, like for my
Sure.
services or for whatever else they need, or if they need to go see another specialist who takes cash, or if
Yeah.
they need to go to physical therapy, because my physical therapy place can't take insurance anymore. They
Hmm.
tried, you know. So
So what's it called? Do you want to
yeah.
plug it? Is there a name? Is there a website for your nonprofit, or is it still
No,
pending
it's still
TBD?
pending.
Okay.
It's just started.
Just
I
started.
just found the lawyer who's going to help me set it up,
Awesome.
and I just paid the retainer, and
Okay.
we're about to
So
go.
the
So I'm very excited.
it's a baby seed for now.
Yeah, it is.
Let's see here. Another question. So let's say that there is a listener, another clinician,
Right.
physician, neurologist, anesthesia, I don't know, someone who's like, I'm kind of curious about the space. Like, what's one piece of advice that you would give them just from your many years of experience opening up and operating and running a successful practice?
I mean, as far as doing ketamine infusions, or just in practice in
Just in the
general?
practice in general,
In
or both.
general, or
Yeah.
both?
Yeah. Or
Yeah.
both. One
I
for each,
mean,
maybe.
I think as far as the practice in general, I mean, I think it's probably pretty obvious, but from the get-go, organization is really, really key, and finding the right person is really key. And, honestly, I've also had a lot, because I didn't have a lot of money when I started. I have had a lot of luck with hiring really young
Uh
people
huh.
who managed to really step up to
Wow.
the task. Yeah. So, I mean, that's something that has been also really gratifying that I didn't really even think about, is watching employees grow and watching them like, evolve and have all these skills. And I sent somebody to phlebotomy course, and now she's a phlebotomist. And so like, that's a part of it that I didn't really even think about. And it's really rewarding to give jobs to people. To create jobs is
Mm-hmm.
really rewarding. But at the same time, just preparation is key. Like just before you do it, I would prepare for at least 2 years.
Okay. Take some time to prepare.
Take some time. Do not do what I do and
Business
just
plans.
decide to
Okay.
launch overnight. So yeah, business plan, like getting the right people in place, and also really figuring out how you're going to deal with your documentation.
Mm.
And I went through about 5 EMRs I'm still not happy. But, really figuring that out, which has been very challenging for me because my patients are complicated and the notes are really long. But yeah, figuring out efficiency early on, like how to be efficient with gathering the data you need and
Yeah.
also with documenting. And I
Mhm.
have a scribe, and that has been life changing. So, an AI is coming. So that's going to be, that will be a lot easier. But yeah, I would say preparation and also just get a really good lawyer to help you set it up.
Totally. Totally.
Like really get a good lawyer to
Yeah.
set it up the right way from the beginning. And if you're adding different services, they should all be different S corporations.
Mhm.
And so that whole piece of things, if I didn't have good lawyers, it would have been really hard. I
Yeah.
got really lucky with that.
And it
Yeah.
makes sense because we are
Yeah.
trained as medical professionals, but we didn't go to law school,
No, we didn't go to law
and we don't
school.
want to.
And we don't know how to set up a
Yeah,
corporation. Or if you
exactly.
have two corporations, how are they going to interact with each other? Can they
Totally.
be in the same place? Can they not be in the
Yeah.
same place? I mean, I have Edinger Pain Management, and then I also have Edinger Infusion Services because the infusion suite is now a separate
Interesting.
company, and that's for liability reasons. And I never would have even understood that had I not talked to
To getting excellent
lawyers.
legal counsel.
Yeah,
Yeah,
exactly.
it kind of reminds
No
me of
idea.
a patient who might search and Google search their own symptoms on,
Right.
online, and they're
Right.
like, by the way, I have X, Y, and Z. It's like, well, yeah, you can try to look it up online, or you can just go to an expert who
Yeah,
knows exactly what's going
exactly.
on. So same thing with the legal side.
Yeah,
It's like
yeah.
talking with
It's
experts
really
in that
important
space.
to get the right type of corporation. Yeah, so that's a challenge. As far as ketamine is concerned,
Hmm.
I mean, I want to see ketamine expand. I think it's great that it is expanding. I hope that more pain physicians will also take it on to treat chronic pain, which I think is more challenging because it does require higher doses.
Hmm.
It requires a different kind of monitoring system. But basically, I think what I would advise people is that, ketamine, while it is very safe, and in the beginning it can seem deceptively safe, if you've been doing it for a few years, you just have to recognize that it's really important to get people medically cleared and psychologically cleared before they go through it. I really am a big believer in that. Like everybody gets cardiac clearance and psych clearance. In my case, they might get pulmonary clearance from, sleep apnea, or if they need a CPAP machine, or, it can go on and on and on depending on what their problems are. But I mean, for a basic infusion, you know, if somebody's older, I mean, definitely get a cardiac clearance.
Yeah,
Even if it's low dose, just do it.
just do it. Just be
Just
safe.
do it because you don't know. I mean, I've had people can become very hypertensive. That's kind of like surprising, like out of nowhere. I mean, it doesn't happen very often, but it can. So we just have to mitigate all the risks we can, and that will keep our industry safe too, right? We'll all be able to continue doing this if we take these precautions and document, like, okay, if you're a therapist, oh, okay, you had a psychiatrist who endorsed this,
Yeah.
doing this, or yeah, there's a lot to work out as far as that's concerned.
Yeah. And I feel like I know we talked earlier before this podcast about how you're kind of doing it in the ICU style with like
Basically,
gurneys and
yeah,
continuous
I
vital sign
have
monitoring
a
and
miniature
CRNAs.
ICU.
And
Yeah,
I really appreciate that.
yeah,
Especially the doses for
yeah,
CRPS. Like,
yeah.
I mean, it's some pretty high doses so
It's
I think
very
it makes sense
it's
to be
around
as safe as you can.
600 on average, I would say. It goes
Uh-huh.
up to 900.
Yeah.
But yeah, I have essentially an ICU ward
Yeah.
with
It's
5
great.
beds. I have telemetry. I have a crash cart. I have end tidal CO2 monitoring.
Beautiful.
I have like everything you can think of that you might need. Every drug you can think of that you might need, because I have to be at the absolute. I have to operate as the absolute safest way I possibly can.
I love that.
I mean, for the sake of my patients, first of all, but also for the sake of our industry.
Yeah.
You know what I'm saying? It's like really protect me and everybody else who gets into
Mhm.
this field, that like, okay, we're all responsible. We're very responsible providers, and we're going to do this the right way.
Right. And I
Right?
love how
So-
you're not only thinking about you and your patients, but also like the industry as a whole. Because
Yeah.
there can be some possibly bad actors
Yeah.
or some people doing some strange, unusual
Unusual
things. And it's
things,
like,
or things that are kind of on the edge of like safety, maybe.
Yeah.
Or, yeah, I do worry about that a lot. I mean, I came from an era when I first told people I was involved in a program doing ketamine. Everyone thought I was insane. They
Mhm.
thought I was in some fringe program. I basically got laughed at ASRA, for example,
Wow.
when I went down and like I had a poster presentation at ASRA, and they all just thought I was nuts and rolled their eyes when I heard about Schwartzman. And now every anesthesiologist wants to get ketamine, by the way. So, I came from an era where like it was considered totally crazy. And now I'm just really, really happy that it's out there and people are using it.
Right.
And I want to support that. And I want to help other physicians get started. And I think that every pain physician out there should be able to offer ketamine as like, yes, this is one of the things in our toolbox.
Yeah.
Right?
Yeah.
I
It's
mean,
one tool.
how
It's not
many
the panacea.
CRPS patients are going to be saved if that starts happening? Or people will be prevented from even developing severe CRPS. Right? So I'm really,
I love that.
yeah.
Yeah. Thank
I want to
you.
support people.
So let's see here. I'm curious because I know as a clinic owner and a clinician, physician, dad, husband, and I know you wear a lot of hats. How do you personally juggle your patients, your business, the staff, the kids, or whatever, the family, the dog, the cat?
I don't have kids. I can't imagine.
Okay.
God bless everybody who does. I have 2 dogs and a husband. My husband is extremely supportive. He actually started the business with me. He is still involved, and he's like the IT guy. He's like the construction guy. He still helps me with CME organization and like my paperwork. And I don't know. I mean, honestly, I don't know how I could even do this without that kind of person in my life. So I got very, very lucky. And yeah, it's a real challenge, especially in the first few years of practice. Like you basically work 24/7.
Right.
And it's kind of, yeah, you have to go through that period, but it does get better and better. And now like I have an RN that works part-time, and she deals with all the opioid monitoring and like, and to make sure that we're all in compliance and that everybody has all their UDSs. And so that's a godsend, because in a pain practice, that's a huge time consuming task.
Yeah.
So, but yeah, basically I have to force myself to not think about it.
And also what I'm hearing is a lot of delegation and
A lot of,
outsourcing.
yeah,
And leaning on support. Because when we
yeah,
open up a practice, like people think we're doing it by ourselves, but we're doing it with
you
our
can't.
partners,
Yeah.
our staff, like our lawyers. Like
Yeah.
for me, my wife, Kim, like she does all the marketing and kind of the operations, and she
Right.
helps me with taxes. And
Yeah.
like,
Yeah.
like I couldn't, she helps me look at contracts and just
Right.
like, I don't think I could do this by myself.
No.
So for anyone who's considering opening one up, it's like, yeah, get a team.
Yeah.
Really good
Oh,
team.
you
Get a good
definitely,
CPA,
yes.
get a good lawyer.
Oh my God. And the
get a good
CPA
partner.
thing, I'm telling you, I've been through, I don't know how many accountants. I mean, that is a really hard thing to find a good accountant. And now my accountant is like out of college, 25 years old, but you know what? He's the best guy I've ever found.
Nice.
He often happens to be my office manager's boyfriend's brother.
Okay. So leaning into your network, finding people who might be
I'm
good.
telling you, this kid is the best I've ever seen.
We might have
He's
to.
really like, he's like resolved so many issues. So that's what I'm saying. Like, you never know where you're going to find your help, and be open-minded. But yeah, without my husband, I mean, it was just him and me when we started, literally. He was answering the phone and learning how to pull PMPs and doing all this crazy stuff. And yeah.
Maybe even cleaning and mopping and sweeping.
Yeah, cleaning.
I mean,
he still comes in and cleans.
You're going to be wearing a lot of hats.
Oh, yeah.
When you start up your practice.
It is. It's hard. Yeah, we used to stay at night and like clean everything. We used to, after all the ketamine infusions, we'd like take up all the linens, clean all the beds.
Wow.
Like I put in all the IVs. I still do a lot of IVs. I mean, basically I'm the nurse. I push on meds. I'm basically a nurse and a doctor.
Yeah. Wow.
Some of my patients are like they've never seen a doctor do that kind of stuff before, and they were really funny about it. They're like, "Do you know what you're doing?"
It's true. It's true.
I had one kid who's unfortunately been in hospitals his whole life. He's like, "I've never seen a doctor do this. Are you sure you know what you're doing?" That's really funny. But yeah, my nursing skills have come a long way, and I have a much greater appreciation for what nurses do.
Oh, absolutely. Absolutely.
After changing beds and bed bands, and like I've done it all, literally, like I had to. So,
Thank you for doing all of that.
Yeah.
So as we wrap up, we just have a few kind of rapid fire fun questions, maybe to shift gears. So this one is kind of a desert island question. So let's say that you're on a desert island and you only have one book, one movie, one type of food on that deserted island. What would they be? So one book, one movie, and one type of food if you're on a deserted island.
Wow. Let's see. Movie-wise would be Star Wars.
Nice, nice.
Book-wise would be, well, I guess only one book or a series.
Either one.
The Dune series.
Ah.
I could read that forever. And the food would be probably Mexican food. Yeah.
And we have some really good Mexican food in SoCal. We're very blessed.
Very, very blessed. Yeah. I could basically eat that every day of my life and be happy. So
awesome.
Yeah.
And let's say after a really long day, you're like, man, I worked so hard at the clinic. What's your go-to way to just relax and de-stress?
I mean, honestly, at night, it's usually just collapsing on the couch. And luckily, my husband's also a chef, so I get really good meals. So that is a real blessing. Like, that really helps a lot. But like on the weekends, I mean, honestly, spending time outside, because you're stuck inside so much, and like just going out with the dog, sitting in a park, walking around. I do some bird watching. We go to a lot of museums, which is really helpful. That takes you out of your mind completely. So yeah, we do a lot of that kind of stuff. And yeah, it's great.
Wonderful.
Yeah.
Except for the weekends that you're doing the 10-day
Unless I'm doing the 10-day protocol, or I get called in because of some sort of crazy emergency. That happens too sometimes. So yeah.
I'm curious, do you have a hidden talent or hobby that most people would be surprised to learn about?
I don't really know. I don't really think so. I mean, I guess the bird thing is surprising. I mean, I do know quite a bit about birds.
And you can identify them by their
I wish I could. Some birds I can. Some birds I actually can identify by their call, but I wish I could do more of that. But yeah, on site, I know pretty much every single common bird that you'd come across in North America.
Whoa, that's amazing.
Like for the most part. Some of the warblers are, more challenging, but yeah.
Let's talk about time travel. So if you could go back in time for a day, any time period in the past, where and when would you go and why?
Wow, that's a hard choice. What do I pick? You mean like professionally or just like anything in the world?
I mean, you had mentioned museums. So like, is there any like, I want to go see dinosaurs. I want to go see, I don't know, the medieval times with knights. I want to go back into the flappers in the 1920s, roaring 20s. Like, what's a fun time for you?
Oh, what would be a fun like time period to see? Oh my gosh. Let's see. I don't know. The beginning of the printing press.
Ooh, the Gutenberg.
Yeah, that might be a wild time.
It made a huge impact.
Yeah.
Huge.
Yeah. It's like kind of like we got to see the beginning of the internet. Like I got to see the beginning of the internet because I'm old enough. Sure. So I was like, God, the printing press must have been wild though.
Yeah.
Right?
I wonder if they even realized it at the time.
I don't know. I think it was a pretty rapid change though, because all these little pamphlets got sent out for all these different issues. And all of a sudden, I mean, not that the population could read that much, but yeah, I think within probably a decade, it probably did change a lot. I don't know. I'm just speculating.
Sure.
I'm not a historian, so I don't know.
And I kind of feel like, you had mentioned AI, like in a way we're at kind of the cusp of that as well. We are at the cusp of that.
Yeah, we got to see that too, which is really cool. Yeah, so I'm looking forward to ambient AI being able to actually be my scribe. So then my current scribe can go on and do a whole bunch of other tasks that need to be done. But yeah, I'm looking forward to that. I think it's going to happen in the next, 8 months to a year. So yeah, I've been keeping tabs on that.
Beautiful.
How can I use that?
I'm going to pick another fun one. So that's not on my list, but just came to me. Let's say that you could no longer be a physician, neurologist, pain specialist, but you had to do some career, some job. What would that be if you couldn't be in the healthcare field?
Wow. I can't even imagine. Okay. What would I be that would not be in the healthcare field? I don't even know. My brain's been I was like, I would be a neuropsychologist if I wasn't a doctor. I find that fascinating, but like that's in the healthcare field, right? I don't know.
As you're thinking, I mean, for me.
Yeah. What would you be?
I think I would make movies, which I guess I'm kind of doing right now as we're making a pseudo movie. Yeah. But something, creative and impactful. Yeah. And I feel like movies and documentaries, like I think that'd be like in a different world, I would have gone to USC film school and made some be the director or producer. Like, I think that'd be fun for me if I could be in the healthcare. I don't know.
I think for me, I would probably like to like go into art history or curation or curation of antiquities.
Wow.
Or like anthropology, which I always found really interesting. I also have a great love of philosophy. I was a philosophy major in school, so I might just go back and get a PhD. That would be actually really fun. Go back and get a PhD. Yeah, so I don't know.
Yeah, I love it. Well, philosophy breaks down into the love of wisdom, and I feel like you've dropped a lot of wisdom nuggets here today.
Yeah.
So really appreciate you being here, and I'm really honored that I got to meet you and work together with you the past couple of days. Yesterday was fun. For our listeners, if they want to learn more about you or contact you or just follow you on social media, what would be the for patients even?
Yeah, I mean, I have a website that's extremely rudimentary, but all my information's out there. It's just edingerpainmanagement.com.
Okay.
And we do have an Instagram page. I don't even think I know what it is. I think it's just Edinger Pain. But yeah, I mean, I'm happy to talk to anybody who's interested in ketamine, the use of ketamine, how to do it. I'm really happy to talk to anybody about that.
Yeah, I feel like your expertise, because I know we have a lot of ketamine clinics specializing in mood disorders, treatment-resistant depression, PTSD, etc.
Yeah.
But some clinics are a little bit leery or a little bit cautious with the CRPS.
With the CRPS thing.
So I feel like
I would be happy to do anything. And, even if they can't do it to the level I'm doing it, I can tell you anything can help CRPS patients. Anything. Anything is better than
nothing.
I mean, some ketamine is definitely better than no ketamine. And I'm also sure we can work out different ways of doing it. Like I'm doing this too, simpler ways of getting the same response. I'm playing around with IM ketamine too, actually in some of my patients. I mean, in some cases it actually seems almost as effective, which is really fascinating. So maybe there's all sorts of ways of doing it that is not nearly as complicated. Or if you get CRPS cases that are not as extreme as mine, right? They don't need such an extreme approach as I do.
Right. Interesting. So custom tailoring exactly to the patient, because every patient is different. Some people may need that high intensity.
Somebody might need it, but you know what? If you catch somebody really early on, I bet you anything they really don't.
Wow.
I don't think so. So yeah, I'm really willing to support anybody who wants to try it.
Awesome. Thank you. Well, as we wrap up, and is there any other last thoughts, comments, questions, concerns, complaints that you have as we wrap up?
No, I mean, I think that, as far as this industry is concerned, it's really exciting, but I also urge people to really use their best judgment in terms of safety and really make sure that you get everybody cleared in whatever way you think you need to. And don't try to go too fast or try to get too many people in too quickly, because we have to just be really careful, for the sake of all of us.
Yeah.
It's
a beautiful ending. Yeah. And I remember hearing this idea that what's necessarily legal may not be what's wise.
Exactly. That is the key point. It's it could be totally legal, but it can also become totally illegal if we don't watch out. Yeah.
Thank you.
All right.
And with that, we will close out. Thank you so much.
Thank you. Okay. Take care.